Hello, this is a midterm review video for HKIN466, Clinical Exercise Physiology at St. Francis Xavier University. I'm Dr. Palmer, and I will lead you through this midterm review. We'll touch on some of the highlights from the first few sections that we've discussed. Of course, this isn't exhaustive. There's much more material in the notes. Please feel free to ask me about it, email me, or stop by office hours. This is just a primer. So, consider the scope of clinical exercise physiology. That really helps to underpin, to anchor our context. In the past, you were sick or healthy and we didn't really know much about the disease. Now, we've started to characterize diseases a bit more. And with our increasingly sedentary lifestyle, we're bringing about a new class of disease. Chronic disease nowadays are non-communicable. They are dysfunctional. They're incurable. There's some thing that's going wrong with a physiological system or multiple systems, and we can't cure it immediately. It's not something that can be fixed by abruptly changing one system. But we can generally control these diseases. We can use medication, we can use surgery, we can use lifestyle change, and a big part of that is exercise to help control the symptoms and hopefully reverse a lot of these diseases. But being that they're inherently multifactorial, things like surgery and medication may not be as appropriate, because if the disease is systemic, wouldn't you also want a systemic therapy like exercise? Now, with exercise, we can't only focus on the fact that physical activity is a likely therapy. We do also have to consider the other factors that go into improving lifestyle, such as diet, changing bad habits like smoking, affecting stress, etc. The treatment, though exercise is systemic, also should be multifactorial, since these are complications that likely lead, in general, to chronic disease nowadays. So, these non-communicable diseases, these population-based diseases, we study in a few ways. We do it at the population level to get a sense of relationships or correlations between multiple factors, to get a large data set. We can do that by looking at the incidence of disease in a population, screening everyone in the population for certain characteristics. And by doing this, we attempt to identify relationships, things that tend to improve or tend to worsen as the disease becomes more evident or more prevalent in the population. And that gives us a really nice indication of where to target therapies, or at least where to look further for the cause of the disease, a potential treatment or a more effective therapy. Now, two ways that we can look at studies at the epidemiological level or the population level are incidence studies, which are longitudinal, follow one group, hopefully one large group, over time to see how a factor changes or the association changes. Or prevalence study, which takes a snapshot at one point in time across a large group of the population, multiple age ranges, multiple ethnic groups, to see how a factor changes across ages at one point in time. However, these types of diseases are only an association. They don't dictate cause and effect. It doesn't mean that if you see one thing change in tandem with the disease of interest, that the factor you're concerned with or the factor that's related will reverse that disease. In order to be able to make comments on cause and effect and find a therapy that will reverse the disease, we need to isolate in clinical or intervention studies by manipulating single variables. So we control everything except for the variable of interest, the thing that's related, the thing that you want to control. We try to avoid any biases either personal as investigators or the expectation bias of participants by randomizing and blinding the subjects. And we want to make sure that the response isn't just because we randomly selected a bunch of responders. We cross over the groups so that both groups will do the intervention trial and the control trial, and the net effects that we observe can therefore be said to be due to changing the factor. A clinical intervention study, these are small distinctions between the types of intervention studies, but a clinical study would be the treatment of disease by affecting one factor, and an intervention study might be considered the prevention of disease by changing one factor. So using these tools, we were armed with a basic understanding of the science involved. We set out to look at some diseases. To start, we took a look at the big picture. Disease ends up causing premature mortality or contributing to premature mortality. So we looked at the large scale. Is there any evidence that being active, engaging in exercise, is related somehow to the incidence of death? And one of the earliest studies in the 1950s, they used a very practical hands-on approach to do that, found that in conductors, which typically had a more active lifestyle than drivers, the risk of mortality was halved. The risk of these individuals dying from whatever reason, and it wasn't portioned out into cardiovascular causes or some other disease or some other accident, for instance, just whether or not the conductors ended up dead at the end of the study, was reduced compared to the drivers who had a more sedentary occupation. And so that gives us some indication that perhaps being more active contributes in some way to that reduction in mortality risk. We followed this up by measurements of body weight and uniform size to show that, well, these individuals, as a secondary effect of being more fit or more active, as a confirmation, also observed reduced weight and reduced uniform size. So we can say that our assumption that conductors are more active is actually true, is effective. And we move to a bit of a more comprehensive view by looking across, albeit a fairly affluent white male population at the university level. By following them for a number of years, we observed that the initial fitness category of these individuals tended to impact the relative risk of mortality, where here we see the lowest fitness men and women had the highest relative risk of mortality. There's a large drop even just moving into the second fitness category, the second fitness quintile, and a progressive gradual reduction thereafter, where the most fit individual tends to have the lowest relative risk of early mortality. So this trend holds up. Being more fit seems to confer some reduction in mortality risk. We further went to differentiate between physical activity and physical fitness. Is it that you need to be active, or is it that you need to be fit? And when we control for fitness within those individuals that are engaged in physical activity, we don't observe as convincing a trend for reducing the relative risk of mortality. For individuals of low, moderate, and high physical activity, if we standardize across these groups for the fitness of these individuals, if we correct for it, there's no relationship between relative risk of mortality and the degree of physical activity in these individuals. But if we do the same comparison, the same correction for individuals of low, moderate, and high fitness, we see this potent reduction in relative risk, just moving from the lowest third of these individuals into the second third, with no additional reduction thereafter. That's not to say that's not the case, but there's this potent effect, at least, of being somewhat fit. Now, there is a little bit of a disconnect here, I suppose, and a question that's left unanswered. You have to be physically active in order to be fit, But here it seems that the benefits, the potency of fitness outweighs that of being physically active. Overall, there's a general agreement. Being more fit is better, and increasing your fitness to a higher degree is better. It reduces mortality risk, whatever the risk happens to be, whether it's death from a specific disease. All-cause mortality risk is how we're going to describe it. If we have a high fitness or increase fitness the most, there's the largest reduction in mortality risk, at least here summarized over 13 years. So we have quartiles in this case, where high fitness is quartile 4, and the greatest improvement on the right is quartile 4. PF 1 and 2 are physical fitness assessments 1 and 2. So quartile 4, in both cases, the closest corner of this graph has the absolute lowest risk over 13 years for all-cause mortality. These are the individuals that were of the highest fitness and also increased or maintained their fitness to a higher degree than the rest of the population. All the way to the opposite corner, the least fit individuals that increased their fitness the least had next to the highest all-cause mortality risk. So, if we have some general understanding that fitness or activity, that exercise benefits longevity, benefits mortality risk, what is it? What are the individual benefits? Is it just an aging thing? Is it just a lifespan thing? Or is it due to some change along the way in the incidence of disease, a therapy for those diseases, etc.? So we turned our attention to one of the biggest societal chronic diseases impact factors of our time, which is obesity. Here, we see one of the two main schematics for how obesity develops. We observe that in obese individuals, the uptake of fat into the cells is a lot greater. The oxidation of fat from the cells is a lot smaller. And a lot of that has to do with these transporters that are relocated to the membrane. A lot like glucose is taken up by GLUT4, fat in the muscle is taken up by fat CD36. This is just the name of the transporter. We have the same amount in obese versus healthy muscle, but more of it is just on the membrane in the diseased muscle, in the obese or the type 2 diabetic muscle on the right. And you can see that repartitioning here. Now, what that means is simply that more fat gets in. If we use that fat for some reason or to achieve some goal, it's likely that it won't cause much disruption, but because we see this large accumulation in triacylglycerides, somehow that seems to impact things like insulin signaling and the normal function of the cell. The accumulation of triacylglycerides in the cell seems to be at least related to, and in part the cause of, a lot of the dysfunction that we observe in obesity and diabetes. It's not immediately clear from this slide what causes the dysfunction, but we did link this oversupply of nutrients to dysfunction in our second example. Now, this is not the animated slide, but this is the schematic of the mitochondrial-based dysfunction, the free radical-based dysfunction, or the redox dysfunction. Remember that electron flow and the pumping of protons are linked. They are necessarily linked. You can't have one without the other. And this oversupply of fat into the obese or diabetic cell also oversupplies the mitochondria, specifically here the electron transport chain, with NADH. NADH is the thing that we break down all the foodstuffs that we ingest into. We produce NADH. So what that does is it inputs the electrons that we rip off of our food into this chain to achieve the goal of making this proton gradient. We should harness the gradient to make energy, but that is only activated to a high degree when we have a large demand for that energy. You might be thinking exercise, and you'd be right if you were thinking that. If we don't exercise and we just create this really reactive, saturated situation where we push more fat into the mitochondria or push more of these reducing equivalents, that's what NADH is, into the mitochondria, we create this pressurized system where we're likely to generate free radicals, things like superoxide that damage the cell, that interrupt signaling, that might be the missing link between the oversupply of fat in obesity and the dysfunction that we observe with diabetes and other diseases. In order to alleviate this situation, we've got to get rid of the gradient. We've got to create a pull through the electron transport chain. And the only way to do that, other than breaking the system apart, which would result in us dying, is to exercise. The ATP utilization rate is what dictates the pull, and what sets that utilization rate is how quickly we are consuming ATP, how quickly we're exercising, how much we're exercising. So we think that that is at the center of why fat accumulation causes dysfunction, why it's related to chronic diseases. And this is highlighted by the athlete's paradox, where only having a high intramuscular triglyceride content isn't related one-to-one with insulin sensitivity. In the obese, it is. And that's why it's a candidate for increased study, for more therapy, because we observed high IMTG and we observed insulin resistance. But we also observed that in the trained. We observed high IMTGs, however, the association, the correlation was broken. They were insulin sensitive. What we think lies at the center of this paradox is the oxidative capacity. In the obese, they are not generally very active, they are not generally very fit, therefore they have that reactive situation we just described and a low oxidative capacity in the muscle. This is different in the athletes where they have a high oxidative capacity, and we think that this is what is the biggest factor, the most important deciding factor in mediating if high fat storage in the cell results in insulin resistance. This is a potent modifying factor to dictate whether or not high fat in the cell will result in insulin resistance. And it's been easy to blame fat because we see associations like this one. This is not fat necessarily. Here is mitochondrial size with insulin sensitivity. This supports the point that we just made, that oxidative capacity is integral in modifying this response. We observe that for those individuals with a large mitochondrial volume or big mitochondrial size, they also tend to have the greatest insulin sensitivity. But as an observational relationship, we're not convinced until we do the intervention study where we take unfit individuals with small mitochondria, we train them to increase the mitochondrial volume, and we monitor the secondary change in insulin sensitivity. That's what we're doing here. We increase mitochondrial size along the bottom, and insulin sensitivity goes up. This is an intervention that says there is a cause and effect relationship linking these two things. The specific mechanism we're not too sure, but we're fairly confident if we increase mitochondrial size, we'll increase insulin sensitivity. Now, there are other players in the obesity-diabetes debate. Here we see fat tissue that progresses from normal lean fat. It increases in size as we continue to load it with food and then not use that food, where eventually the vascular supply is not sufficient to support the normal metabolism in those cells, and the cells die. And what happens is these cells will then release inflammatory factors that we think are implicated in systemic inflammation and disruption of normal function. So here we see the hyperplasia and hypertrophy of adipose cells, the increase in number and the increase in size of adipose cells. which leads to a reduction in blood flow, potentially hypoxia, but certainly cell death. And with that cell death, we get recruitment of the immune system. Macrophages are recruited by whatever the apoptotic signals are. This is a fancy word for death of a cell death. And then this triggers the release of an inflammatory profile of factors, C-reactive protein, tumor necrosis factor, some fatty acids, etc. And these travel systemically to relay messages to other parts of the body saying, there's a really bad situation going on in the adipose. It might benefit you to protect yourself or to alter function. Somehow it disrupts function. So we don't know exactly how we can switch obesity or switch diabetes on or off, but we know the general theory is an imbalance in energy supply and demand. We could acutely improve these situations by increasing the usage of onboard fuel, but it's not an immediate fix, right? Again, controllable, but not curable necessarily, even with exercise. Now, perhaps unrelated to diabetes and obesity, but generally a situation that appears with those, a comorbidity, if you will, hypertension. Hypertension we describe simply as a systemic increase in pressure in the vasculature. High blood pressure often occurs with obesity and with diabetes, but it might not be directly related or a consequence of those diseases. Here, we think that hypertension can be related to obesity just because of the increased pressure of the excess fat and the weight from outside the vasculature pushing inwards. It could be a side effect of unhealthy lifestyle choices that lead to obesity and diabetes. Here we see some damage to the arterial wall, stiffening of the arterial wall, and when the arterial wall becomes stiffer, it's less compliant, it's less resilient. It doesn't expand, it's not elastic, and that can lead to increases in pressure as well. So somehow damage to the wall we think is related to hypertension, as well as a whole host of other lifestyle factors like increased sodium and increased fat intake, for instance. But here we're going to focus on endothelial damage because it ties in nicely with the next sections that we'll talk about, the cardiovascular disease sections. So if we have this stiffening of the wall and it's less compliant, it's more likely that we'll register these high pressures as the heart continues to pump. The downside is that as the heart continues to pump and it needs to generate these high pressures, that pressure makes it harder for the heart to do its job. It increases the work rate of the heart. In one of the papers that we looked at, the rate pressure product, a combination of how quickly the heart pumps, the heart rate, and the pressure that it has to generate is a measure of how hard the heart is working. And the increase in the pressure, the afterload against which the heart has to pump, means that it has to work harder, generally leads to hypertrophy, and can contribute to chronic heart failure in the future. Again, exercise here seems to be protective. There is some population-based relationship where those individuals with the highest fitness and or the highest activity tend to have the lowest incidence of hypertension, right? The fact that the vascular system seems to be somewhat relaxed after exercise, and this lasts through a workday. It lasts for 24 hours in free-living individuals, which is pretty amazing. So it's not surprising that we see a relationship like this where high fitness and high activity reduces the incidence rate of hypertension. Now in the past, we've typically thought that moderate intensity, general guideline exercise is the way to go because with pressure being required to exercise and with pressure also being the problem in hypertension, exacerbating that situation is not advised. We don't want to spike the pressure in the blood more than is necessary to gain the benefits of exercise. However, there's sort of a sea change in this field now where we're starting to get a bit more information on more intense, vigorous type exercise. And as you can see here, there's a general linear trend for greater improvements with intensity of exercise. So while we don't have much convincing evidence now, there are indications that the guidelines could change in the coming years. We might advise any exercise, not just moderate exercise, and certainly the degree of the benefit that you'll expect will scale with the intensity of the exercise that you partake in. So let's summarize some of the main points. Without rehashing the details of the papers and everything we've just talked about, let's talk about the main points of the first half of this course. One, we've established clinical exercise physiology as a field, and we've defined that it concerns itself with treating disease. Treating could be preventing chronic disease, it could be the reversal of existing diseases, but it's using exercise as a therapy for chronic disease. And so far, it seems very effective. It seems to be a potent therapy because it's systemic in nature. It corrects the immediate problems associated with diabetes and with hypertension. We have this sense that acutely exercise works, but full correction of the disease requires continued engagement. If we consider obesity, diabetes, and hypertension, the three specific examples we've talked about so far, exercise benefits them specifically by, using the fat that we've accumulated, by disposing of the proton gradient in the mitochondria, by releasing the pressure in the mitochondria. It also acutely reduces hypertension post-exercise. We have this vascular relaxation that occurs after exercise. So we have these specific therapies that acutely correct or contribute to corrections of each of these diseases. And you can see how if we add multiple bouts of exercise up over a long period of time, that eventually the disease itself could be reversed. The candidacy of exercise as a therapy is remarkable in that it's systemic. The cluster of non-communicable diseases, it's appropriately treated by exercise because they are systemic and the effects of exercise are also systemic. We're not just targeting one receptor. We're not just targeting one depot. We're not only targeting muscle with exercise. We target fat as well. We target the heart. We target the immune system. So at least in these first few glimpses, we've found exercise as a convincing therapy. I hope that you take this information and it clarifies for you some points that may not have been clear. I hope that you think critically about some of the papers that we've talked about in class. I hope that if you have questions, you'll reach out to me and let me know. Otherwise, good luck studying, and I'll see you at the midterm.